All righty. So this is our poll QR code. There are some copies of it on paper passing around. If when you're done with it, if you want to put it at the back or put it on this table here, because obviously we can't keep this slide up the whole time. It would be great if you don't mind coming to the front. We don't bite. And we're very excited to be here. This is a crowded session, which means that it is a mask-friendly session. Please feel free to wear a mask as we are packed in like sardines. That's a little echoey, isn't it? So welcome. We're going to be talking about involuntary retention on hospital medical floors. In 2017, Illinois Supreme Court ruled that any setting was a psychiatric setting and required involuntary paperwork to hold patients who lack dispositional capacity. So we have been required to fill out paperwork on every patient. And we did a little poll of all the people in CL Psychiatry in Illinois who were members. And most of us actually are doing this. And none of us have actually had a patient go to court, with the exception of Dr. Hunko, who might have one next week. But right, it's overburdened our system. And so I started ranting about this and asking everyone what clinical practice is. And we developed this session to try to think about what is a good answer to this unsolvable riddle that people have written about in the past. You can see Nancy Byatt's great, but getting old article on this from the ACLP journal a number of years ago. And so we're hoping that not only will you take our poll, but that at some point we may write this up with some interesting information about how different states are doing this and what we think the standard should be. So I'm thrilled to introduce this distinguished panel. I'm Lisa Rosenthal. I work at Northwestern. Everybody's going to talk for about 15 minutes, and then we're going to have some interactive sessions. Please don't forget to use the microphone. Professor Marie Tobin is Chief of Adult Psychiatry at the University of Chicago, and she's going to present the history of involuntary admission to psychiatry and associated dispositional capacity assessments. Dr. Stephanie Cho is an assistant professor of psychiatry at USC Keck School of Medicine, and she is the medical director of inpatient CL services and program director for the general residency, with our condolences. She will discuss bias and discrimination. And I'm sorry, I'm reading the wrong line. She's going to discuss criteria commonly required for involuntary commitment and ethical principles. Dr. Andrea DeSimone is the chair of psychiatry at Bay Health Medical Center in Dover, Delaware. She's going to discuss bias and discrimination in mental health law. And Dr. Kenneth Novoa is chief of CL Psychiatry at Denver Health and the University of Colorado. I was very fascinated to learn that he is not only a CL psychiatrist, but also board certified in addiction and brain injury. He's going to discuss inconsistencies in involuntary commitment policy across a variety of U.S. states and how this impacts the clinical work of CL psychiatrists. And then hopefully we're going to have about 20 minutes for audience participation. We have a few ultra brief case descriptions to prompt discussion. And hopefully we're going to arrive at some sort of consensus about the utility of completing involuntary paperwork. I'm sorry, I put the wrong slide in here, but all of us have no disclosures. I'm so sorry. I seem to have left the proper slide out that had all of our names on it, but none of our speakers have disclosures. All right. Dr. Tobin, I'm going to make you up.
Thank you so much, Lisa, and thank you for spearheading this workshop and for inviting me to participate. I'm delighted to be here. I'm delighted to see so many people here. I think it highlights just what an important topic this is to our field. I plan to cover in my talk, as Lisa already said, a little bit of the history of involuntary commitment, also what we mean by capacity evaluations, particularly as they apply to dispositional capacity, and then talk a little bit about potential future directions. As Lisa said, I have nothing to disclose. Just to start off with, civil or involuntary hospitalization is defined as by the U.S. Health and Human Services as a legal process by which a person is confined in a psychiatric hospital because of a treatable mental disorder against his or her wishes. So 3 points I'd like to make here. First of all, to remind ourselves, it is a legal process, so we do need to fill out those forms correctly. Interestingly, it specifies in a psychiatric hospital, but in the great state of Illinois, that is a movable feast, and that it is very much against the wishes of the patient. So a little bit about the history of involuntary hospitalization. So going back to Hippocrates and the founding of medicine, you know, the first tenet was always primum non nocere, first do no harm. So non-malfeasance was the sort of foundational principle. And that was very closely allied to autonomy, that patients could agree to treatment. But even then, there was a recognition that there were a cohort of people who didn't have that ability to make decisions about their treatment. And all from that time, all up through the 14, 15, 1600s, the practice was that people with mental illness were locked away. That was the treatment that was available. It tended to be a legal process and usually initiated by families. And then really, it wasn't until about 1752 when, in fact, all psychiatric hospitalizations initially and at this time were involuntary. That was the only way that people were in the hospital, and thus began the practice of hospitalizing people for the sake of psychiatric treatment. This trend continued, and in about 1833, more state-supported asylums were established with the Worcester State Hospital. And this is interesting because early commitment laws focused on the need for treatment. States were acting in parens patriae, a presumption of compromised reason, but still they remained primarily less than optimal conditions, jails, almshouses with very poor conditions. And even though there was a push to open specific hospitals, the majority of people continued to be treated in these less than optimal conditions, and they were state specific. And as Dr. Cho will take you through, it remains very much like that there are probably 50 jurisdictions with different state laws. There are a lot of common themes, but there are differences. So then actually, I hope Dr. Pao is not here, because the NIMH was actually established or opened in 1949, but this draft act governing hospitalization of the mentally ill was issued in 1951. And again, the focus of hospitalization during that time was on treatment. But with the arrival of the 60s, influenced by the use of medications, a shift to community psychiatry, there was a greater focus. There was a concern and that too many people were being hospitalized against their wishes, that this was an infringement of people's civil liberties. And so with the swing to deinstitutionalization, a narrower concept was adopted for the basis for involuntary commitment. And in 1964, DC and California adopted dangerousness as the sole ground for civil commitment. By the end of the 70s, most states had revised their commitment statutes to conform to the dangerousness criteria. So in other words, the presence of psychiatric symptoms and risk to self or others. It was a clear and convincing standard. If you read about this, you see that at the federal level, there's been very little opining on or any guidance about that. It was very much up to states. So some recent evolutions have been a swing in the pendulum away from that dangerousness, smoking gun kind of criteria for involuntary hospitalization, and more of a trend towards increasing the recognition of the value of psychiatric inpatient care for patients who are chronically at risk, but perhaps not imminently dangerous. So here we have entering again, this sort of coming the full circle, this idea that there are a cohort of patients for whom inpatient care is absolutely necessary. And most states in their laws include the prospect of severe deterioration, the presence of disabling illness, and general inability to care for self. Now, recent developments are, I think, very interesting. Since the 1950s, there's been a drastic reduction in state psychiatric beds. I think there was over 500,000 in 1950. I think in 2020, there's something like 37,000. And it has represented a continuous downward trend in state psychiatric hospitals with the potential for longer term treatment. There have also been some very interesting economic pressures. There's been a growing trend towards managed mental health care, and that has meant shorter hospital stays when patients are hospitalized, greater push towards outpatient treatment, less reimbursement for treatment. And another very interesting thing has been, and I think this is very relevant for us, is a sort of a shift in cost from psychiatric hospitals, particularly state ones, which are very poorly funded and are funded by states, to provision of psychiatric care in the general hospital, which is where we come in, because then it becomes federal funding through Medicare and Medicaid, and the same applies for nursing homes. So a little bit of some of the pressures, some of the sort of societal and economic changes that have led to what we're all very well aware of, is to general hospitals increasingly filling the gap and treating psychiatric patients. I want to switch. I do want to talk about, in a little bit more detail before I switch, about recent updates in the state of Illinois. So 2 issues were at stake: what constitutes a mental health facility, and whether a facility must comply with the mental health code in order to provide mental health treatment to an individual that has already been admitted to the facility for medical treatment. So the first, I just included the details of the case for basically a patient was admitted, and during her stay on the medical floor, the patient who had previously been diagnosed with schizophrenia was followed and seen by a psychiatrist. And it was from this case, known as Linda B., that the court decided that while the patient was hospitalized, she received both medical and mental health treatment. And the court held that a facility or section thereof capable of providing mental health services that does in fact provide an individual provides individual mental health services is a mental health facility within the meaning of the mental health code. It endorsed a broad definition of what mental health facility is. And in the second and most recent case is Julie M. And this was, I again included the details of the case. Somebody admitted on September 14th after swallowing batteries. We have such a patient on our service right now. Anyway, the long and the short of this one was that the patient was considered a danger to herself and wasn't ready for discharge until October the 4th. And a petition, even though the patient had 2 sitters and was followed by psych during her admission, she wasn't deemed medically stable for transfer until October the 4th. And the court ruled that a facility must comply with the Mental Health Code's admission procedures, even if a patient has already been admitted to a facility for medical treatment. So while the Illinois Supreme Court held in both Linda B. and Julie M. that the procedural requirements of the Mental Health Code apply to individuals receiving psychiatric services while on a medical unit or floor, both courts affirmed the lower court on the basis that the respondents, the hospitals, failed to demonstrate whether and when they provided psychiatric treatment and when that was done involuntarily. So what does that mean for us CL psychiatrists in the great state of Illinois? It means that the day you start to provide involuntary services, that must be filed in court, which we do. And the second thing is that we're running 600-bed inpatient psych facilities because our patients are, at least in my hospital, we don't have inpatient psych, so our patients are scattered throughout. So I wanted to switch track now and talk a little bit about decisional and dispositional capacity. So we're very familiar with this. I'm teaching no new tricks here. Decisional capacity is part of a specific medical or surgical procedure, 4 key components: the ability to understand the information needed, the ability to appreciate the clinical circumstances, the ability to exhibit a rational process of decision-making. In other words, the ability to process options and compare them. And finally, the ability to communicate a consistent choice. Now, decisional capacity's context is very important. It is a dimensional parameter. They talk about the decisional capacity gradient. It pertains usually to a single decision, and it follows the doctrine of informed consent. Dispositional capacity, on the other hand, is a term coined by our own Dr. Bourgeois and colleagues in 2017. It refers to the capacity of a patient to participate in discharge planning following a hospitalization. And in reality, we are called so often, I think, to these cases. We're called all the time. It is a future-oriented determination. How will this patient function post-discharge? It's complex and multidimensional. It has both decisional and performative components. It's significantly influenced by biopsychosocial and cultural factors. And then 16% of ICU patients lack decisional capacity and are without advanced directives of surrogate decision makers. And this is an interesting study of a large cohort study of a large number of patients from a large healthcare system. And delirium was detected in almost 1/5 of the patients, with the median age being 56. If you do the math at an institution like mine, it means that at any one time, there's 100 to 120 delirious patients getting ready for discharge. I just thought you might be interested to know that the electronic health record DSM-based algorithm correctly identified over 90% of delirium diagnosis made by us. Isn't that nice to know that we're affirmed by an algorithm? Across services, this is stuff we already know, but when you see it in this number of patients, the odds of delirious patients returning home was significantly reduced. And there were rather sent to acute rehab or nursing homes. And then just a reminder, I was kind of shocked to see this again, that the adjusted mortality risk is dramatically increased in those delirious patients. So in their work about decisional capacity, they propose that there are steps in integrated psychiatric approach to capacity determinations, evaluation of what question is being asked, doing cognitive testing, very important, collateral information. Do we need more tests, social work evaluation, OT and PT, and then summing it all together and presenting that to the team who make the ultimate dispositional decision. This, I think, we have a real role to play here, and I think we need to take leadership in this. We need to work on developing some quantitative dispositional scores and development of some clinical pathways. And I just wanted to share with you a clinical pathway that we at U of C developed for our inpatient CL service around decisional capacity. It was done using Agile MD, which I think is a U of C product. It took 9 months to grow, same length as a pregnancy. And basically, because it took buy-in from psychiatry, geriatrics, ethics, and RIT team, and it can go, the outcomes can be, the patient has capacity, but you have to give them the information. It has a drop-down menu for the Applebaum criteria, or the consult should go to geriatrics, ethics, or we should see the patient. It's in use, it's live, but I don't have data yet on whether it's made any difference. And so I'm going to stop there and hand it over to my colleague, Dr. Cho, who's going to take us through the states. Thank you.
Okay, so, going back to the concept of involuntary retention on hospital floors, for us, it comes back to what does that actually mean? Legally, where are we? There's been quite the evolution over time, but currently, where are we? And the question is, or the answer is kind of, there's a lot of things that are similar, but then a whole lot of ways that we diverge. Dr. Novoa will talk about many of the ways we diverge and how that impacts us in our clinical practice. I'm going to try to start first with how do we agree? So I have no disclosures. If anyone wants, you can download the most updated slides. But I think that they're on the app now. So I think we're okay. I'll give a sec for people to. Okay. So back to involuntary civil commitment. Again, just to reiterate, it is a legal intervention. An authorized person who has been invested by the law can order that any individual with symptoms of a serious mental disorder and meeting whatever other specified criteria that state has determined can be confined in a psychiatric hospital, and nowadays potentially outpatient as well, for some period of time. Every state in the United States has passed laws authorizing some form of involuntary psychiatric commitment. And to take a moment, we are going to keep our scope to the United States and mainly inpatient commitment, because that's even more than we can fit in for today, to be honest. But every state has passed some form of law. All of these laws have in common that it incorporates due process protections and the constitutional rights of each individual. That includes a qualified right to refuse treatment, and then the general right not to be confined unless posing a risk of harm. In Lessard versus Schmidt in 1972, this case was a Supreme Court case, which is one of the few things that the Supreme Court has actually kind of spoken on civil commitment. And in this case, they determined that the same legal protections as criminal defendants are still afforded to patients undergoing civil commitment, though it's a civil process. So though it is a clearly civil process, we're just in that weird space that also it's all the same criminal processes. And so the main rights that were granted and reinforced is the right to counsel, the right to remain silent, and the right to exclusion of hearsay by non-experts. So within the US, there is actually quite a wide variation of the actual standards and procedures that are utilized. The paperwork you do, the timing, the duration, but by the 1970s at least, there were some common principles that had been widely adopted. And those common principles come down to 4 main areas. One is the presence of mental illness, or dangerousness and or grave disability, and then the need for treatment. So symptoms of mental illness, what does that actually mean? While it's required in every state that there be symptoms, what it actually denotes is quite variable. And many states really don't even define it beyond serious mental illness. The most encompassing definition I found was from SAMHSA, discussing that serious mental illness itself is a substantial disorder of thought that grossly impairs judgment, behavior, or ability to negotiate the demands of life. What most states also do is that they actually exclude, either explicitly or through kind of practice, substance use disorders, intellectual disability, and dementia. So O'Connor versus Donaldson in 1975 was a landmark case. It was a Supreme Court case. And this case really codified the very few federal limits we have regarding civil commitment. And specifically, they stated that a state cannot constitutionally confine an individual who is non-dangerous or capable of surviving safely in freedom. And that could be with or without assistance. And so that's where our core criteria across all of our states come from, really that case of the dangerousness and then the grave disability. So dangerousness remains a fundamental criterion in nearly every state, though it's not any longer the only exclusive criterion. Dangerousness is considered overall to be the likelihood to cause serious physical harm to oneself or another. And as Dr. Tobin talked about, imminence had really been codified by Lessard versus Schmidt, but since then, it's actually evolved quite a bit more, where now not all states agree that imminence is necessary. And really the states that have been more recently revising their statutes have taken imminence out of the criterion. Grave disability is recognized in most states as a criterion, and it's generally considered the inability to provide for basic personal needs to be able to survive. However, it doesn't need to be by oneself. If there are willing, able, and responsible persons willing to support the individual, and with that person's support, they're able to survive, they do not need to be involuntarily committed. This is kind of considered the corollary to dangerousness, where it's the passive corollary, right? So how bad are we talking? How bad does it actually need to get? And the 2 main cases that kind of help define this for us is Humphrey versus Cady, which was another Supreme Court case. And in that case, the response was that the symptoms and the danger has to be great enough to justify such a massive curtailment of liberty. Lake versus Cameron sort of added to that, in which they decided that the deprivations of liberty, the liberties that are curtailed, should not go beyond what is necessary for a person's protection. So essentially, that became the less restrictive option standard, where you must consider a whether there are any less restrictive alternatives to involuntary commitment. Prior to that, it was not required and not codified. And so we talked, Dr. Tobin talked about the clear and convincing evidence. So we talked about how severe something needs to be, which is still pretty vague, to be honest. But then also, how clearly do we need to prove it, or how much evidentiary basis do we need? And so that came in Addington versus Texas, where in this case, essentially, the court ruled that beyond a reasonable doubt was an unacceptable and unrealistic standard to meet for involuntary commitment due to the, kind of dynamic nature of what we do and the likelihood that a diagnosis may change and evolve as you get more information and longitudinally observe the patient. On the other hand, they also felt that preponderance of evidence, which a lot of scholars will put at more than 50%, was also not acceptable, because that standard is based on this idea that it's about equal. It's like a 50-50 chance, or a little bit more than 50%. And that states that the community shares an equal amount of risk and burden in in putting someone on a civil commitment, which the court rejected. And they said, no, the risk to the individual is much greater than that to the state. And so we must have a higher burden of standard. And so clear and convincing evidence is considered sort of the recommended standard. Those states do vary, either going through gradations or just kind of honestly not meeting the standard. And so the last part that comes into this is the need for treatment. Arguably, this is the essential purpose of involuntary commitment, is to obtain treatment for someone. It's required in most states, and I give the quotation marks because it's not necessarily explicitly stated in most of the statutes. Sometimes it is explicitly stated as part of the definition of illness, but often it's implicitly stated via the assumption that there is an available and effective treatment for the psychiatric illness. And so something to note as well is that in many states, commitment alone, so the hospitalization alone, is considered treatment. If you actually want to medicate over objection, that requires a finding of incompetence or incapacity and a separate legal petition. So the ethical principles. I think everyone in this room is here with me where ultimately we're not doing this for fun. We don't like, taking people's rights away. It's that we're doing this for the good of the patient. We're doing this for ethical reasons. But what are the actual ethical tenets behind this? We have our 4 pillars: autonomy, non-maleficence, beneficence, and justice. So in respect for autonomy, this one gets kind of hard, right? Because inherently, involuntarily committing someone is coercive. It's curtailing their rights. And these are already highly vulnerable individuals who have their rights curtailed. And so the standards that have developed with the goal of trying to minimize the disrespect, essentially, to someone's autonomy, right? And so pursuing the least restrictive option and release at the earliest opportunity are ways that we can try to minimize this. On the other hand, there's a concept of therapeutic jurisprudence. And this concept holds that autonomy, the person's autonomy, is inherently limited by the symptoms of mental illness, that someone has had symptoms that are so severe that it does start to impair their autonomy. And so commitment is actually an attempt to restore and promote the person's autonomy. Non-maleficence, again, the curtailed liberties, social stigma, social losses, economic hardship, not to mention trauma that can result from seclusion and restraint. These are all things that happen in that, are we really avoiding harm? There's a study from 2007 that showed that involuntary commitment actually does still negatively impact future experiences, even in voluntary mental health And so beneficence. This is sort of, I think, where we all typically are. It's rooted in parens patriae, which is to act in someone's best interest. And really what we've done as a medical, culture is this idea of benign medical paternalism, where the expert knows best. And this typically has privileged beneficence over respect for autonomy. But what's concerning as we become more and more aware of this is also the real issue of police power and public safety, and how much of an issue is the state's protection of its citizens in this situation. The primary purpose of detention is supposed to be treatment, but not prevention. And so that's a way to approach it, but it doesn't quite answer the question, which is this just? Is it a just distribution of resources where we are prioritizing resources to those who are the most ill, but at the same time, are we taking away the prioritization from those who may be voluntarily seeking treatment and resources as well? At the same time, with the treatment itself, there is disparity between states and jurisdictions, and what type of treatment you're going to get is going to be dependent on where you physically are, whether it be in Illinois or California. There is also racial disparity. There are just, Andrea will talk about, but the racial impact of involuntary commitment is quite uneven, right? And really thinking about, is this just, is this equitable? And how does this current civil commitment system bias and discriminate against others? So I will turn it over now. Yes, it is.
Okay, so I'm going to be talking about bias and discrimination in involuntary commitments. So I have no disclosures. Okay, so let's start with first what we know. So we know bias and discrimination exists in medicine, especially psychiatry. Psychiatry is particularly vulnerable to bias due to reliance on psychiatrist discretion in both diagnosis and treatment. The fact is that 2/3 of healthcare providers hold biases against marginalized groups. So let's talk briefly about explicit bias and implicit bias. So the first one is explicit bias. So Brother Bear and his friends are very aware that they are excluding Sister Bear from their club. With implicit bias, the person who designed this lovely outdoor space wasn't like, oh my God, I hate wheelchair people, let's exclude them from my building. They didn't think that at all, but clearly they've designed a space that is inaccessible is accessible to only able-bodied individuals. And we also know that psychiatric treatment has been an instrument for some questionable practices at the very best, and at times a tool for abuse, and reflects how the perception of abnormal behavior is shaped by society's values. So let's start first at 1851, when we can consider the proposal of a psychiatric diagnosis of drapetomania, which was proposed by a pro-slavery psychiatrist physician who pathologized enslaved individuals' desire to flee slavery. So then we move forward to the 1960s, when the DSM was revised, adding the words hostility and aggression to the schizophrenia diagnosis, which we'll have more on that later. This was also the time that homosexuality was pathologized and coincided with the rise of conversion therapy. More recently, in 2011, a silent protester in the Occupy Cal movement was detained under California's 5150, which is the involuntary retention policy in California. And so the basis of this article was saying, well, this person was a silent protester. So what dangerousness did they have to themselves or to others? And so what was the basis for this detainment? And then in 2014, a multi-part article in the Mercury News, this was also in California, that described the drug prescribing practices for children in foster care. So this was from the perspective of both children as well as people who were assisting with them. They had said they were prescribed stimulants, they were prescribed antipsychotics and mood stabilizers for diagnoses that they were found later not to have. So we're going to talk about three marginalized groups for involuntary commitment. So we'll talk about race, gender, and the LGBTQ plus population. So let's first start with race. So studies assessing bias in involuntary petitions are available, but most offer only speculation for causative factors. So this first study focused on involuntary admissions to public institutions and was a review article of 16 articles. It found that in 14 of the 16 articles that Black individuals were admitted involuntarily more than white individuals, and that difference was statistically significant in 10 of those 14 articles. They listed the prevailing reasons for this phenomenon in 1989, which sound pretty familiar to the ones that are thrown around today. So things like racial bias, lower socioeconomic status, mistrust of medicine. So people were brought to treatment at a later stage. And then we also get into something that they refer to as weak family relationships in this population, which is incredibly problematic to start talking about. And then they suggested the increased prevalence of psychiatric illness in this population. This second study examined involuntary commitments in minority ethnic groups in both the UK and internationally. Over 9,500 studies were pooled, but only 71 were included. Most were from the UK. There were 5 from the US. And they found that Black Caribbean, Black African, and South African patients were admitted involuntarily more frequently than their white counterparts. And they also found that non-native groups to that particular country were admitted more frequently than native populations. Nearly half of the studies offered no explanation for this variation, and they offered untested hypotheses such as ethnic disadvantages, is how they termed it. They did speak about the perceived increased risk of violence for this population. They also spoke of increased police contact, mistrust of general practitioners, and they also talked about this perceived increased prevalence of psychiatric illness. So we'll hold on to that for a second. So compared with non-minorities, patients with serious mental illness who are ethnic minorities are more likely to have worse outcomes. So they are less likely to get a callback. There have been studies that showed that middle-aged white women received a callback more frequently than someone who is a working class Black male. They're less likely to be treated via up-to-date guidelines. So for instance, say you have a Black male who's presenting with first episode psychosis, are you more likely to recommend a first-generation antipsychotic because you perceive that they can't afford it versus somebody else who you say, okay, they must have insurance, I can prescribe a second generation, no problem. They're less likely to receive a prescription at their first visit to a PCP for a psychiatric problem. And they're also less likely to engage with treatment, including treatment follow-up. They are less likely to return to work, and they're less likely to see symptoms improve. On the other hand, they're more likely to utilize emergency treatment, and they're more likely to be involuntarily committed. So what if studies found that the strongest predictor of an admission diagnosis of schizophrenia is? It's race. So let's talk about where this idea came from, that Black people are more likely to have a psychotic illness than white people. So the increased prevalence of psychotic illness in Black individuals can be traced to diagnostic criteria for schizophrenia. So there clearly is a diagnostic bias. So ethnic minorities are 3 times more likely to be diagnosed with schizophrenia. White individuals are more likely to be diagnosed with an affective disorder. Psychiatrist Jonathan Metzl, who is the author of The Protest Psychosis, traced this to DSM-2 changes, which was in the 1960s, to the diagnostic criteria. And he looked at this through the lens of one Michigan hospital in which the diagnosis of schizophrenia was used to detain and treat individuals who were protesting civil rights. So prior to this, schizophrenia was seen as like a white housewife kind of disease with symptoms in the charts with words like docile and autistic. The DSM-2 utilized masculinized aggression to describe a patient with schizophrenia. So the quote from it is, he is frequently hostile and aggressive. He noted that both the diagnoses of white and Black patients were changed after this. So you could see like the diagnosis of schizophrenia like scribbled out with white patients and put an affective disorder in its place. And the opposite was true with Black individuals. And this reflects the racial unrest at the time. So you can see from this Haldol ad that's quite provocative, and it evokes the image of this assaultive, agitated Black individual. And he writes, anxieties about racial difference shape diagnostic criteria, healthcare policies, medical and popular attitudes about mentally ill persons, the structures of treatment facilities, and ultimately the conversations that take place there within. So let's move on to gender. So it appears that women are committed at overall lower rates than men, though at higher rates for similar behaviors. So overall, men have higher rates of involuntary commitment in almost all of the countries that were studied. Notably, women have higher rates in Switzerland, Brazil, and China. In this first study, they looked at all admissions to a Dublin hospital for 2 years. So this was about 1,000 patients, about 1,200 patients, 1,000 were voluntary, about 170 were involuntary. And the most common involuntary diagnosis was psychotic spectrum for men, and for women, it was an affective disorder. The second one down here looked at all admissions to an adolescent psychiatric ward in Finland. And this was about split 50-50, about 200 admissions, 100 voluntary, 100 involuntary. Boys and girls with violent behavior were more likely to be admitted involuntarily, which follows. But the risk was stronger in girls with an odds ratio of 6.2 versus 3.3 for boys. Even when controlled for diagnoses, the girls with disruptive behaviors, so things like hostility, temper tantrums, and breaking property, so things that are maybe okay for the boys, they had a greater risk of involuntary treatment for similar behavior. So this author writes, and I wanted to quote this author again because it was so eloquent. It is a serious ethical and legal problem if similar symptoms result in different interventions in girls and boys. There may be a risk of unnecessarily depriving girls of their liberty when they break rules in a way that is accepted for boys. On the other hand, there's also the risk that severe symptoms in boys will be ignored and the treatment they need is denied. Let's move on to the LGBTQ+ population. While trans individuals were more likely to experience psychologic distress than their cis counterparts, there are no data regarding involuntary commitment in this population. So this would be a great avenue for a trainee or somebody looking to investigate this area. For what data that I was able to find, so this is from the 2015 US Transgender Survey. There were 28,000 respondents in 2015, and they're currently collecting data for the 2022 study. So if any of your patients or yourselves want to take it, they are open to data collection, and you can just hit the link and it'll take you right to it. They did find that 39% experience serious psychological distress in the month prior, and this is versus 5% of cis individuals. 40% have attempted suicide in their lives versus 4.6%, and 7% have attempted in the last year versus 0.6% of cis individuals. So there's no data on involuntary commitment. So let's recap. So what does the data support? So ethnic minorities, especially men, appear to be involuntarily committed at higher rates. So they're more likely to enter treatment via law enforcement. They have longer inpatient stays. They have more readmissions, and they're more likely to receive poorer quality of care. Women are committed at overall lower rates than men, though at higher rates for similar behaviors. And while sexual minorities report greater levels of psychiatric distress, there's no data to comment on the rates of involuntary commitment in this population. So where do we kind of go from here? So as most of us are both academic and clinical psychiatrists, we must treat both the patient and the culture to reduce mental health disparities. So first, let us be reminded that the data is highly suggestive, but they offer no clear solution on what the next steps are in this case. So next, we must strive to increase diversity in the field. And this starts not just at the faculty level, which would be great, but this also starts at the college and medical school recruitment level. Some of the more innovative departments I've learned have specific faculty development programs for people who are underrepresented in medicine. So this maybe will address that leaky pipeline of academic medicine. And lastly, we must remember to treat both the patient and the culture. So when I'm learning about bias and discrimination, all of a sudden I feel like I'm filled with all of this inspiration about what to do with the DEI committee at my institution. But I tend to forget that at the end of the day, I'm really treating the person in front of me with a serious mental illness who needs my help. So we're all doctors and healers at our core. And so it is our job to heal both our patients and our culture. So with that, I will pass to Ken.
Okay. All right. So thank you all for coming today. I'm going to preface this by just saying that a lot of the laws, the way they're written, a lot of statutes across states are very difficult to like understand. I'm looking at you, Virginia. If anyone here's from Virginia, like ye old laws are very difficult to read in Virginia. So I preface this by saying this is my best interpretation of what I read in the statutes. And I've already confirmed that a lot of the things that I interpreted a certain way, I talked to my colleagues from these states, and they said that's not the way it's practiced. So I think the ideal situation here is I want to go through a sample case that is fictional, but inspired by many of the people that I've seen in Denver. And I'm going to go through what we would do in Colorado in this case. And I'm hoping part of the discussion later will be like how you would have done differently in your state, depending on how you do things in your, not only just state, but even within a hospital in a certain state. Okay, good. I thought I just removed everything. Okay, so with that being said, we'll just start with a case report here. So basically, we'll start off with, imagine you have a 50-year-old man brought into the emergency room after being found disheveled, sunburnt, wandering on the streets, talking to himself, and telling others that he's the Lizard King. Based on prior documentation you have in your system, you see that he has a history of schizophrenia, stimulant use disorder, methamphetamine type, and a history of treatment non-adherence. You see that he has a medical history of hypertension, and labs, the pertinent labs obtained in the emergency room on this visit would be an albumin of 2.8, and his urine drug screen was negative. And then in terms of social history, you see that he has several years of experiencing homelessness, but he does have some support from a family member in the form of a sister who can from now and again let him stay in her house for a little bit, give him a little bit of money. So it's a little bit of support, but nothing that he can really kind of hang his hats on. So keep this case in mind. And so some of the initial questions that we want to ask is, so first of all, who sent the person to the emergency room? So now we have the process of getting someone in for an emergency psychiatric evaluation. And then later on, we'll talk about the process of going from there to to involuntary commitment into like an inpatient psychiatric facility. So the list is very long, and this is non-exhaustive by any means. States have pointed out many, many different types of people that can send someone in to an emergency room for psychiatric evaluation. 3 of these such examples would be professionals, peace officers, and any responsible adult. So in terms of professionals, this usually tends to include people like physicians, psychologists, LCSWs, the variation across states, you'll see that some states require us specifically to be a mental health professional. Some states say that it can only be done by professionals. So state by state, it really just is quite a variety of different people who have the authority to, who are seen as professionals, who have the authority to send the person into the emergency room for evaluation. In terms of peace officers, this is usually thought of to be police, sheriff departments. I was in Colorado. I found out this includes wildlife parks and rec officers. So like just every state has like a bunch of different peace officers that have the authority to bring in people for evaluation. And then this is where it starts getting a little sticky. So the way I read things, it seemed that in certain states like Kansas and Wisconsin, police, you can only be brought in for an emergency evaluation by a peace officer, which seemed really crazy to me. But then when talking to some people, it's a little bit more nuanced than that. So I guess it's not like in Wisconsin, I guess more people can bring someone in for evaluation, but a peace officer has to be involved if you want to commit them for suicidality. So then it gets a little bit difficult if you want to do like grave disability for like mania, for example. So it's just really interesting how this just varies across all the different states and territories. And then in terms of any responsible adult, this is something that advocacy groups are saying that they would want to see more of the any responsible adult. So over half of the states allow any responsible adult to petition the court for an emergency evaluation. So If it's like an imminent case, then obviously it's not going to wait until the person petitions the court and you get like the evidence and the judge says it's okay and then you bring the person. If it's going to be imminent, which is another word we'll talk about in a few minutes, then it's a different process. But if you're a loved one, if you have concerns for your loved one or your friend and you want to get them evaluated, there is a way for you in the community and over, like I said, over half the states to go through a process where you can have them eventually, after a judge says it's okay, to get them brought in for an emergency involuntary psychiatric evaluation, like in an emergency room setting. So some states have even more specific qualifiers. So some states will say it has to be a family member or a specific family member, like a sibling or a parent. Others will say that it has to be a friend. So again, state by state, territory laws just vary greatly. And so I think the reason that a lot of people advocate to have more of these type of people, that's not good, be able to bring in people for evaluation is that there might be some biases. So like if you, for example, rely on only professionals to bring someone in for an evaluation, then you may be excluding people that just don't come across a professional's window. Like, so if you have really serious mental illness and you just don't end up in front of a professional, you might not never get the help that you need. On the other hand, if you kind of rely too much on peace officers, as you can imagine, then this may lead to more arrests than actual sending people in to get evaluations and the help that they need. So who sends a person in for evaluation is pretty interesting to see on a state-by-state basis. So now, in terms of why they were sent for an emergency evaluation, I think Dr. Cho mentioned earlier, for the definition of mental illness really matters in a lot of these states. So you have to pay attention to what the different statutes say in the different states about what does and does not constitute a mental illness, because there are some states that do allow, for example, substance use disorders, alcohol use disorder to count as a mental illness. I don't remember seeing a state that did say for dementia or developmental delays, but I think it's possible that one of them might, but I didn't see it in my quick survey. So why a person, the definition of mental illness is one of the things you have to pay attention to when you see why a person's getting sent in. And then in terms of danger to self, others, or grave disability, the vernacular we're a little bit more used to. I'll talk about it a little bit more in the next phase of the talk, but one thing to consider is just the wide variety in states. So for example, like was alluded to earlier, some states, like I believe Delaware, don't have any particular language to what grave disability is, whereas other states like Pennsylvania and Oklahoma, their definition might be a little too of a high bar. So for example, in Oklahoma, they're saying for the version of grave disability is that that the person has to pose a substantial risk of immediate serious physical injury to self or death as manifested by evidence that the person is unable to provide for and is not providing for his or her basic physical needs. So if you're waiting to the point where the person is on the verge of death, it might not be the most ideal situation. You might want to have a law that lets you bring them in a little bit before they're imminently about to cause serious physical injury to themselves or die. So it just the variety of different ways these things are interpreted across the states is very interesting to see. And again, we'll go back into this in a few minutes. And I apologize I'm talking so fast because this is like a lot of information to do in 15 minutes. So I'm just trying to get through as much as I can here. And then how long do you have? So we'll talk about the actual duration of custody in a few minutes. But in some states, they even have a pre-evaluation custody limit. And so that's basically where an evaluation by a designated person must be done within a certain time frame, or else the patient has to be released from the custody. And again, to the best that I can tell in Virginia, you have about 8 hours to decide whether a person is going to go through the process or not. I believe New Hampshire is also similarly with 6 hours. But again, I would love to get everyone's input at the end of this talk about like how this is all written in the law. So there's a really, I don't have enough time to go into it, but there's a really crazy case from Virginia, I think like 10 years ago, where like a politician's son was like mentally ill and then stabbed the father, the politician, and then killed themselves. And there was like a whole thing about they only had, I think at the time it was 4 to 8 hours. So 4 hours, 8 if you get a judge's permission. Now it's 8 to 12 to find someone in a psychiatric bed. They couldn't find a psychiatric bed. They let him go. And then he did this to the parent and himself. So it's really wild to see like how time constraints differ in different areas as well. Okay, so going back to our case. Actually, before I talk about that, actually, no, we don't have time for that. Okay, going back to the case. So patient's now medically cleared. They're placed on and this is how the Colorado example. So the patient that we just described earlier is now placed on a 72-hour hold for grave disability by the emergency physician, the emergency attending, and then transferred to the psychiatric emergency service, or PES. There in the PES, the team notes that he is disorganized in thought process, tries to walk out multiple times, needs a lot of redirection, but you are able to temporarily redirect the person, and they do accept medications to help calm themselves down. So based on your examination or the person's examination in the PES, and based on the records, you believe he requires further psychiatric admission for further treatment. So now the next step is we did the evaluation and now we think he needs more treatment. Now how do we get him onto the inpatient service? Okay, so in this case, so how long do you have? So this is, as you can imagine, this also varies quite differently among all the different territories. So once the emergency evaluation period has begun, states vary in terms of how long you can keep a patient under emergency custody for evaluation and treatment. So a handful of states give you 24 hours or less to determine whether a patient will be discharged or involuntarily committed to an inpatient psychiatric facility, kind of like the ones we just discussed a couple of moments ago. So on the short end, you might have several hours, less than 24 hours. In Montana, it says, and actually I had a couple of debates with a couple of people about this. So in Montana, the actual statute says you have until the next business day. Is that the beginning of the business day? Is that the end of the business day? So again, this is, if you're from Montana and you practice, I'm sure you know what the local practice is. But again, for an outsider, I have no idea what by next business day means in terms of to make these determinations. Then on the other hand, though, states like Louisiana, I believe, this duration can last upwards of like 15 days. So it's just like a very different state by state. But most of them tend to center around 72 hours. And that's what the case is in Colorado as well. And as you can imagine, many people advocate to have this time period be at least 72 hours so you have a better chance for assessment, treatment, disposition, things like that. So now who can petition to commit someone to an involuntary psychiatric treatment, inpatient unit? So similar to those who can petition for an emergency evaluation, professionals, peace officers, responsible adults can also petition for involuntary inpatient and outpatient commitment, which unfortunately we don't have time to get into today. And this is, again, a non-exhaustive list of, and each individual state needs to you can review all the different people that have this authority. Now, what is worth noting, however, is that in any given state, the group of people that can petition for an emergency evaluation may not necessarily be the same people that can petition for an involuntary psychiatric commitment. One such state is in Alaska, where a family member can petition for an emergency evaluation, but they cannot petition for an inpatient commitment. And it's also worth noting that in some states, it may require more than one person or professional to involuntarily commit someone to inpatient treatment. And what I understood in New Jersey statutes is that you need at least two, one of which has to be a psychiatrist. So again, depending on where you're practicing, and if you don't have a lot of professionals in the area, if it takes a long time to get someone in, having more than one person needed could also delay treatment and disposition as well. And now the last part here. So for what indications can you commit someone? So again, as discussed earlier, for like emergency evaluations, reasons for involuntary inpatient commitment can vary state to state. When examining a state statute, it's imperative that you look at the definitions of terms such as danger to self, in need of treatment, as these will bring into focus what the criteria of the state is requiring for the commitment, and it's not the same from state to state. These definitions also vary pretty widely from different territories. So while some states use language for danger to self that clearly demarcate thoughts or actions of suicide apart from grave disability, other states like Maryland, New York, Delaware, and the District of Columbia do not include any specific language for what we know as grave disability. And it leaves it up to interpretation then whether a phrase like, quote, imminently sustain serious bodily harm to oneself, end quote, for example, would qualify as a descriptor for grave disability in a state like such as Delaware. So for the case that we were just discussing before, would you be able to put that person against their will into a psychiatric facility? Can you say that this person is imminently sustaining serious bodily harm to themselves? As you can see, this is going to be left to a lot of interpretation and a lot of review of case law. And then similarly in states such as Florida, Idaho, Wyoming, to the best that I can tell reading their laws, it's harder to meet criteria for grave disability if you have support from others, kind of what Dr. Cho mentioned earlier, to help you meet your daily needs, which has the potential to place like an incredible burden on the family member or friend. So this may impact our patient here as well. So if they otherwise seem what we would consider gravely disabled, but now you're in a state where, but they do have some support, now it may or may not be up to a judge to decide whether that support is enough to say that this person now is not gravely disabled. So again, theme of the talk, it's very widely from place to place. Okay, so then another variable to examine among the states is the use of different descriptors when you're defining terms such as danger to self, danger to others, or grave disability. So certain states do go into like some serious detail about the severity, the timeline. I think California is one of those states where they just are very specific about what they want. But other states are a little bit more vague in their definitions, again, leaving room for interpretation by the courts. So what your state might consider imminent or potential harm or substantial threat may not be the same in a different state, just to name a few phrases. So I was surprised, and I have not yet verified this legally in Colorado if this is true, but in my entire time in Colorado, I always assumed imminent meant hours to days. And then someone told me that there's case law in Colorado saying that imminence goes up to a month. So now do I feel that someone is imminently at risk to harm themselves? That's a big difference between, I always interpret it like, are they going to go home and do something in the next few hours or days? Now, if that means like a month, that really changes how we kind of interpret these laws, which is pretty wild. So ultimately, it would benefit everyone, obviously, if each state statutes used very clear, non-ambiguous language and were more consistent, across state lines. Okay, going back to our case. So now, the last we left, we wanted to admit this person to an inpatient psychiatric facility. So you begin the process of admitting the patient to the inpatient psych unit on a 72-hour hold. Per hospital policy, you have to test the patient for COVID first, and the test comes back positive. So now he requires isolation and the treatment on the medical service, and they cannot be admitted to psychiatry. So now the patient is then admitted to medicine, where you make all your best friends in the hospital who love you and don't resent you at all. And the CL psychiatry team is now consulted to take care of this patient. So now, can emergency holds inpatient commitments be started and or honored on med-surg floors? So all or nearly all, and again, nearly all I just put in there because I had a really tough time interpreting, in this case, Nevada, South Dakota, and West Virginia, like kind of what they were saying. But I believe in nearly all, if not all states, they do specify in their statutes what type of facility can be used to treat patients on an involuntary commitment. And oftentimes the statutes will make mentions of the facilities having to be deemed designated or assigned or licensed by the state board in order to qualify. So the majority of states do clearly designate general hospitals, whether they're public or private, as an appropriate treatment facility for involuntary commitment for patients. But overall, at the end of the day, it would probably be up to your hospital's designation status with a state board, what psychiatric support and staff you have available to you as to whether or not you could actually start or continue involuntary commitments on med-surg floors in that state. So in Colorado, in this case, we do have it. So just like in Illinois, the general hospital is a place where we can have involuntary commitment policy done. And so we put people on the involuntary paperwork once they get to the med-surg floors. And how long do these commitments last? Quite variable across the states. And again, please correct me later if I'm wrong, but I saw time periods as short as 10 days in New Hampshire, and then as long as several months in multiple states. So in Colorado, once you pass the 72-hour threshold, if you want to admit someone, the next step is 90 days. So you have 90 days on a short-term certification. I think I saw one or two states who that time period is 5 months. So if New Hampshire really is 10 days, then they really do live free or die, because that's really, it should be live free or die, not live free and die. So, but anyway, so that's New Hampshire. So if anyone here is from there, I'd love to talk to you afterwards. Okay. So back to the case report. And I know we're zooming through this. I only have a couple of minutes. So the CL team petitions for involuntary commitment on hospital day 3 while the patient is admitted to medicine. He voluntarily accepts medications, shows marked improvement in thought process and thought content over the course of several days, no longer appears gravely disabled, so commitment is discontinued. Now he's there just to get his treatment for his COVID status. On hospital day 7, patient has an anterior cerebral artery stroke and becomes increasingly agitated and disinhibited over time, often asking to discharge and to leave the hospital. The medical team now asks if the involuntary commitment should be restarted due to the lack of capacity to leave against medical advice. So now what do you do as a CL team? So again, in Colorado, in this case, the patient was clearly improving from a psychiatric standpoint prior to the stroke. As his impulsivity and poor judgment were secondary to the stroke and not secondary to schizophrenia, there would be no indication to petition for another involuntary commitment. And then different hospitals in different states allow for unique policies to address this. So at Denver Health, where I work in Colorado, we have this thing called the detainable patient order. So basically, if you, in this case, lack capacity to leave AMA because of a mental illness, then you go through the regular legal paperwork for mental illness. If, however, you lack capacity to leave AMA because of a non-psychiatric illness, so like a TBI, a stroke, a dementia, then what we have this policy where we can basically have the patient detainable, which means if the person wants to leave, then someone just has to immediately go and assess that person's capacity and determine what's going on. And so for psychiatry, for a CL team, like once it's very clear that it's from like a TBI or stroke, we kind of take a step back with there. It's pretty clear that we don't have to be involved too much. But where this does come in handy with us on CL is when we want someone to be voluntarily treated, who we really do think is a risk to themselves or others or going to be disabled. And so if you're voluntary, I'll say, okay, well, clearly you're voluntary. So by law, I can't put you on any paperwork. But if I'm afraid that you're going to skip off in the middle of the night to do something to harm yourself or someone else, we can put you on this detainable patient order, which means that if in the middle of the night you say, you know what, I want to leave, then the CL team gets paged immediately, no, but 24 hours a day, 7 days a week to go evaluate that person to see if they then meet criteria for mental health holds or legal paperwork. So again, this is going to vary state by state and institution to institution. I am already over time, believe it or not. So additional topics that I didn't even get close to talking about would be involuntary outpatient commitment or AOTs, special patient populations like incarcerated patients, substance use disorder patients, which in Colorado has different sets of laws for involuntary treatment, involuntary medication administration that was referenced earlier, restraint use, seclusion. These are all things that we just don't have time to get into today. But one thing that I did see when preparing for this talk is that there are some lawyers who are trying to build what they call a Uniform Mental Health Commitment Act, where basically they're trying to get states to like en bloc, like join together and have consistent laws. Because, you know, with patients, like they might travel from one state to another, they might move one state to another. And then it'd just be nice if you can have like one consistent set of treatment. Because it'd be really unfortunate if someone really is greatly disabled in Colorado and then they go to a different state and they're like, actually, you know, you're not that bad. So keep living your life, and then bad things happen. So it'd be nice if things kind of were a little bit more uniform, and that's what some people are trying to do with the Uniform Mental Health Commitment Act. Sorry for talking really fast. That's it for my part. Thank you.
Wonderful. Where did the intro go? Does anybody know? I'm sorry, it's not up there anymore. I just want to put up our poll QR code. There are some pieces of paper floating around with the QR code on them. Please take our poll and write in your thoughts. And, you know, there is a open comment section on the poll. I should also say that this is a session with the division directors SIG. And it's a great group. If you happen to be a CL division director, you should come to our meetings and join our listserv because it's incredibly helpful. So right, yes, you can point your cameras at the screen and it's like magic. And we already have 62 responses. So anybody who hasn't filled it in so far, most of you feel pretty confident about knowing the laws in your states. Most of you fill out these forms to send people to inpatient psychiatric units, but the majority of people do not fill out these forms to keep people on med-surg wards who lack dispositional capacity. So, questions? I'm happy to facilitate questions. Please use the microphone because I believe it's being recorded. We're happy to start talking about cases and questions.
Hi. No problem at all. You good? All right. Hi, thank you for doing this. I'm from the same state, Illinois. However, I'm curious as to how things work in other states. In our state, the legal way that you can keep a patient in a hospital who does not qualify under our mental health code as having a mental illness is very nebulous, and it's variable in different hospitals. I was wondering if anybody from a different state has some more codified rules for people that do fall outside of the technical mental health diagnosis, because it's easy for Illinois with someone with a mental illness. We call it a petition and certificate and their help, but then different hospitals have very different interpretations legally about what if they fall outside of that purview.
So unless somebody from our panel has an answer to that, I'll take a shot at it, which is I referred to the great, I mean, there are other articles, but there's an article anchor authored by Nancy Byatt a long time ago now, who talks about the fact that people just feel uncomfortable without a piece of paper allowing them to hold somebody, but it is the standard of practice to determine capacity. And if somebody lacks dispositional capacity, it is in general practice to hold patients based on an inability to demonstrate capacity to leave. And so I think that it's pretty clear in most states that you can hold a patient who lacks dispositional capacity. And that used to be, in my opinion, the standard of care, whether they lack capacity due to a psychiatric illness or any other form. Now it's bleeding, and it's more the psychiatric illness is requiring paperwork, which is why we're doing this session. Does anybody on the panel have a different answer to that? Do you all agree? Let's just see a show of hands that you feel comfortable holding a patient who lacks dispositional capacity, not due to a psychiatric illness, on a med-surg floor. Right. So this is a quorum. This is now the standard of care in the US.
Not without a legal step, because many would consider assault and battery to lay hands on a patient to keep them from leaving.
So the answer without the microphone was not without a legal step, because it would be considered assault and battery. Dr. Levinson, what legal step do you take in Virginia? Sorry.
In Virginia, we have a medical temporary detention order. Lasts 24 hours. You can only do one. There's another procedure in the law for a longer period of involuntary hospitalization. Locally, until he recently retired, the particular special justice had his own idiosyncratic interpretation of the law. And so he said that delirium and dementia, as well as intellectual disability, were psychiatric disorders because they're in DSM. And he used psychiatric commitment to keep people in the medical ICU who had no psychiatric diagnosis other than an organic mental disorder. So it's a murky area, and that within a particular state, there's great variation, I'm sure is true in many of your states.
Let's hear from Dr. Cho.
So that was, the question was awesome and was exactly also what we were hoping would generate from this from this group, which is highlighting, as Dr. Novoa did, as we all did, areas of kind of the care continuum that are sort of pivotal points of a patient's care legally, and where knowing your specific jurisdiction statutes, like knowing what it is and how it will impact your care, but then also in the areas in which it's pretty gray and nebulous, like you're saying, being able to talk to colleagues and others and learn the ethical framework to be able to do your best by the patient and justify it when there is no clear legal statute. And so one of the things we thought about was having people kind of chat with each other. And it's like, in these situations, what have you done in the past? What was your sort of rationalization justification? And be able to rely on each other for ideas and how to move forward. So I think that's one option we could do. We could break up into groups, or we could, I think, continue to kind of go through individual discussions.
We have 10 minutes. We don't have time for groups.
Yeah.
Hang on, you were waiting for a while.
Yes, I'm at the University of Cincinnati in Ohio, and our health system has a medical hold policy that's an order similar to, it sounds like in Denver, your detention order policy. It works pretty well. Our primary team seem to get it. We have a banner in Epic that says, medical hold. The problem that we come across is when the patients actually physically leave, our security officers often are uncomfortable holding them, because they say it's not illegal, it's a health policy, but it's not the law. So they kind of walk alongside them and say, please don't leave. And then when they cross the threshold out of the hospital, they call the Cincinnati Police Department, who pick them up and bring them back, and they sign off. So sometimes we'll do our statement of when the security staff won't hold them. We will hold our statement of observation, which is basically the 24-hour, and that works okay. We just allow it to expire is what we do. So I'm just curious if other people have similar situations and tips on how to avoid the occasional nuisance of that.
I will say from in Colorado, one interesting, it's almost like the exact opposite. We have hospital security, who's obviously separate from our local law enforcement or peace officers. And it's almost the exact opposite. With us, when they see the detainable patient order in our hospital, because as physicians, they always tell us, do not touch the patient. Like, you cannot put hands on a patient. But as soon as that person has a detainable patient order in our hospital, the security officers they go full hands on to keep people in if that's what we think is necessary. And in our hospital, which I can't speak for, this is now a hospital policy. This is not a Colorado policy, but in our hospital, we can keep that detainable patient order as long as we want, as long as we document justifying why we need it every single day. So it's really great. But yeah, it's just interesting how that's like pretty different from us.
Yeah, and to kind of jump in that and talk about how I was doing, so I finished training in Pennsylvania, and now in New York. I can't speak to New York yet, but in Pennsylvania, what we would do is actually petition the first part of our involuntary paperwork and essentially put it on a medical deferral. But in that it was wrapped up, if you're certain this is not related to a psychiatric illness, it gets really queasy because technically the statute is related to psychiatric illness. But this question of do you feel comfortable detaining someone who lacks capacity for medical reasons? I think ethically, yes. Legally, really depends, and logistically, it entirely depends on the particular nurses and security staff working that day. So it's a roulette wheel.
Well, also logistically, who's going to process all these legal forms, right? So in Illinois, as I said, none of us have actually gone to court or had any legal process. So we're filling out papers, but it's practically meaningless.
I think I live in the Wild West, a small county in California. So let me point out first that the general hospitals are not considered designated facilities for treating the mentally ill. Those holds are also only about treating the mental illness, not the severe medical illness they may have, and that there are civil liability issues that could come to haunt you no matter what you do. So what we tend to do is just let's have clear notes. Let's have the physicians that are thinking about it really say why it is that they're doing something that others might later consider to be outside the bounds of their legal authority. And it's like, if you're going to be in the, what do you want to defend if you're in the witness stand? Letting that psychotic patient with myocarditis walk out and die on the street? Or do you want to be defending saying, we just could not in good conscience allow that to happen, and so we gave him Precedex and we tied him down and we gave him antibiotics, and that's just what we do. We've never had problems with it. Now let me add that to petition the court about the treatment of the medically ill, they do not want that. And so they'll say, well, let the public guardian's office petition us.
Yeah.
And the public guardian's office will not take hospital referrals. Once they're out, they'll maybe look at them. So we have this catch-22. There is no outside court. We have to actually think about whether this is a reasonable treatment or not. And some of the stories get really odd. I remember we had a guy with gangrene, and it's like, we have to amputate his finger. He was terribly psychotic. We have to do it. And hand surgeon insisted, and he was going away for the weekend, going to do it on Monday. Can we do it? Can we take this guy who's refusing and agitated? The surgeon comes back on Monday and says, well, I can't do it without a second hand surgeon. No hospital within 300 miles would accept a psychotic patient for an amputation. They stood around and watched, and finally the finger fell off, and the man left the hospital. They told him he was going to die. Yeah.
Oh yeah, sometimes life is weirder than.
Yeah.
And just really quickly, one point to that too is when I speak to my legal department at my hospital, they say, I'm sure this is technically off the record, but it's pretty like they're basically saying like when we think about policies, we think about, do we rather get sued for maybe not following Colorado statute, or do we want to get sued for a bad patient outcome? And almost always they prefer to do the statute, not the bad patient outcomes.
Right. It's an argument about autonomy versus beneficence. Really, it's a ethical principles. Everybody, I'm sorry, but everybody has to use the mic because this is being recorded, and otherwise posterity will never hear you, Dr. Tynes.
Wow, no pressure. Yeah, what I wanted to say is that it's been really interesting. So I trained at University of Florida. Now I'm at University of Washington, and they're actually on like completely different spectrums as far as prioritization of patient autonomy. So it has been really interesting. And looking at the definitions, Washington State actually does include dementia and intellectual disability, which is just fascinating because it's an exclusion in Florida with the Baker Act. And so I wanted to say that I think those kinds of institutional policies and through ACLP, I've actually been able to work with David Carroll as well, and sort of collecting some of these policies, also with Cheryl Fleisch and the folks at UCLA, and they helped to develop our medical incapacity hold at UF. And I think, what I have taken away from all of that work is, number one, it requires an incredible amount of interdisciplinary, multidisciplinary liaising, which hopefully all of us are pretty good at by now. But also it makes what basically is an invisible hold visible. And so by creating a policy, there's greater, standardization and understanding of how to handle these, rather than what we know that we are already all doing, which is, that 16% of ICU patients have delirium, and don't have a decision maker. We are treating against objection, in many cases already. So it helps just sort of like make that more visible and more standardized for just people up.
For posterity. I'm from Rhode Island with some of my colleagues here. We're the ocean state, nice and peaceful and rolling seas, and we're not live free or die, and yet we live by 10-day certification as well, which is quite something. But that's just a point I'll make beyond my question. I was curious if I heard it correctly, why when a detainable patient is not a psychiatric patient, it suddenly becomes the prerogative or the duty of the psychiatric service to do something about that patient when they wish to leave AMA, number one. Within that question, I love that you have a daily ability to keep them there, which compels the question to my colleague in Cincinnati and others: how do you navigate a 24-hour limit on that ability when these patients are head injured? They could be there for, they could be for months in our place, but how do you navigate that when you have a 24-hour limit? It is. Okay. Not unlike what you, okay. So thank you. And
so the answer is that it's indefinite. Do you have more to say, Dr.
Yeah, no, for the first part about why does the burden come to us? So that's what our hospital is trying to work towards, is not having the burden fall on the psychiatrist. We're very good at Denver Health at our hospital of teaching all the other non-psychiatric teams how to go through difficult capacity questions. So I've been in different hospital systems in my career, and almost all of them, capacity is a pretty fair amount of the consults in the service that they have to address. At Denver Health, it's a very small minority, because over the years we've taught the medicine surge, all these teams, that we have a capacity tool on Epic where just follow these steps, ask the person this, and this. And then, so that's why we don't have to really usually get involved in that, because they usually are able to take over that. It's only when it gets really murky, because a lot of times the biggest thing that people kind of mess up is, it's not that the biggest thing, the example I can think of is they want to leave because they want to smoke. So it's so the natural part of you is well, that's not rational. It's well, it's not the smoking part. It's did they rationally get to that decision? That's what counts. It's not your place to impose your beliefs on someone else, saying that smoking is more or less important than whatever procedure you're trying to avoid. So that's when we usually get called in, is when it's a little bit murky in those areas. But overall, for the clear, and we're a level 1 trauma center, so we have a lot of TBIs constantly, and so that's why I think we have this policy where no one questions whether, when someone doesn't have capacity to leave AMA because of a brain injury, no one ever asks us, why is this multi-day, or why is this going on forever? Everyone's no, of course, they can't make any decisions. It's going to be weeks or months till they can. So we're just fortunate in our institution in that regard.
Dr. Muskin?
I'm from New York, and I've been at the same place for 50 years. So I've been through 10 chairs of medicine, a number of chairs of psychiatry, a few deans, et cetera. And I can ask the other people from New York, in 50 years, not a thing has changed at Columbia, for sure. And as far as I understand this, having been an expert witness in a lot of these cases and not ever lost one, it is true. Attorneys do not worry about statute. They worry about outcome. But my question is, in New York, we separate the Department of Health and their rules from the Office of Mental Hygiene and their rules. And we're a hospital. And every place in our hospital, with the exception of CPEP and the inpatient psych unit, are covered by the Department of Health. That has no statute. The Office of Mental Hygiene has a lot of statutes. So we just ignore it. I mean, basically, you know, our ethics committee is involved all the time. I mean, we've had the ethics committee say, what the heck are you guys doing? You know, why are you keeping this person? Well, the person's going to go out. Yeah, but why? So he's going to go out and he's going to come back. But it's been murkily clear to me, as both, you know, somebody who ran things and does these cases and has sat in the ICU with a judge when we were about to amputate somebody's hand who's unconscious but will die otherwise, and as an expert always for the defense in these cases, that juries get it, lawyers get it, judges get it. It's just murky. And in fact, recently I was involved in a case with somebody, I don't think she's here, where they did exactly what you talked about. The documentation it was like Paul Applebaum was writing the notes. They were quoting Paul every day for 17 days with an elderly psychotic woman with metastatic cancer and saying she needs Haldol, but she doesn't need a psych unit. And she's not going home because that would be unsafe. And they kept her for 17 days until she went to hospice. Who do you think sued? The daughter. One of the daughters sued. I was on the stand for 15 minutes. That was it. They said, okay, thanks, bye.
Well, I'm sure that we all have an awful lot of war stories and weird situations as only medicine can take us. We are at 5 o'clock. I was just going to say thank you very much. We now have 104 responses. Most of the people who responded were mid to later career physicians, but we have a lot of trainees, which is great. And ultimately, 51% of you said no to our last question, which is, should all hospital settings require involuntary paperwork to hold patients without capacity? But there were a lot of intermediate comments, and I look forward to reading them, and hopefully we'll get ourselves together to write this up. Thank you all for coming.